Welcome to the fifth installment of Beyond Journal Club, a collaboration between CoreIM and NEJM Group.
The goal of Beyond Journal Club is to take landmark clinical trials and put them into context, telling us a story of how we got to where we are and what it means for how we take care of patients. I'm Dr. Shreya Trivedi, an internist at BIDMC.
And I'm Dr. Greg Katz, a cardiologist at NYU.
Hi, I'm Dr. Julie Barsley. I'm a general pediatrician at Boston Children's Hospital, as well as an editorial fellow at the New England Journal of Medicine. Today, we are talking about asthma, specifically the MANDALA Trial, published in the June 2nd, 2022 issue of the New England Journal of Medicine.
I am so glad we're talking about asthma because you'd think that when a disease is this common, it means we understand it pretty well. But I was so surprised as we dug into the background research for this podcast. I learned that a lot of the traditional teaching that I was taught and that a lot of my peers will still reference about asthma is just either wrong or simply incomplete.
Yeah, and asthma is a disease I care a lot about, not just because I'm a pediatrician, but because asthma disproportionately impacts racial and ethnic minority groups, those from lower socioeconomic groups, and those living in areas with more pollution.
Yeah, this is such an important illness for so many reasons.
And so the big picture question that Mandala asked is, what is the right rescue drug in asthma? But to understand why that's the question that it was asking, we need to first go through a history of how we think about the pathophysiology of asthma.
And with that grounding in the pathophys, we're going to discuss a few of the landmark trials that really changed the way we treat asthma before the MANDALA trial. And this was a little bit different for mild asthma versus moderate to severe asthma.
Right. And finally, we'll take a deep dive into the MANDALA trial as the next step forward in how we manage asthma patients. So I had the chance to sit down with Dr. Jeff Drazen, the former editor-in-chief of NEJM and a leader in pulmonary medicine. And I asked him about how asthma management has changed over the decades. I was shocked to learn that in the 1990s, most physicians were taught that albuterol should be used daily, actually multiple times a day, to help control asthma.
So when I saw an asthma patient in 1988, I said to them, you need to take your beta inhaler 4 times a day. Think about it like brushing your teeth. You do that 2-3 times a day because you know it's the right thing to do.
But that paradigm shifted from brushing your teeth with albuterol 3 times a day to using it only as a rescue medicine. And that shift really started after the BAGS trial in 1996.
Yes, and BAGS, which stood for Beta Agonist in Mild Asthma Study, was led by Dr. Drazen himself, showed that albuterol used only as needed as a rescue medicine was just as good as albuterol every single day for mild asthma symptom control.
And so it was in the 1990s that we really started to conceptualize albuterol, a short-acting beta agonist, as a rescue medication rather than a daily medication. What was the next big development in asthma management?
So the next big step was understanding asthma as a disease that really benefits from using daily maintenance inhaled glucocorticoid dosing on top of the as-needed rescue inhaled beta agonist therapy.
And there's a really good pathophys backing for the importance of inhaled glucocorticoids in asthma. It's worth a bit of a detour as to why before we jump back into the evolving story of asthma management. If we think back to what we were taught in med school sometime, broad strokes, pathophys of asthma is that it's a chronic inflammatory disorder of the airways, leading to some degree of airway obstruction. And that airway obstruction is not just from constriction of bronchial smooth muscles, but also from airway edema and mucus production.
Yeah, the way I think about asthma is almost as an overexuberant immune response within the lungs that's happening in response to various triggers like a virus or an environmental allergen. Over time, the lungs will even start to remodel in the setting of all this inflammation.
Right. That is so important to point out that lungs of asthma patients are thought to have some level of abnormal inflammation at baseline, even when they're between exacerbations.
So this pathophys gets really interesting when we juxtapose that to what we actually see in clinical practice. We see tons of patients with asthma only using albuterol as needed, so they're not getting any medication directed at inflammation.
Right, because if we said inflammation is a huge part of this disease process, then how can we just treat an acute flare-up with a temporary relief measure like albuterol that wears off after a few hours?
Right. That albuterol is a bronchodilator, right? It's just dilating the bronchioles. Yes, of course, it makes patients feel better in the moment, but it's not really getting to the core of what's going on, inflammation.
Exactly. And this brings us to why glucocorticoids, which reduce inflammation, are such an important part of the treatment of asthma.
So having a medication that acts in the moment and then another one that treats the underlying pathophysiologic process fits totally well with my mental model of how we manage other chronic diseases. We don't treat chronic angina just by giving anti-anginals. We also treat the underlying heart disease by treating the hyperlipidemia and hypertension.
Yeah, that's a great analogy, Greg. So ideally in asthma, we're going to deliver an inhaled glucocorticoid directly to the lungs at the time of an exacerbation, right?
Yeah, right. And so that way they can get some anti-inflammatory benefit before the patient gets so sick that they need to come in for systemic glucocorticoids.
Yeah, so that all makes sense to us today. But in the early 2000s, this wasn't so clear.
Yep. So let me summarize. In the 1980s to early 1990s, the teaching was that you treat an asthma flare with a short-acting bronchodilator. But there's a problem with that approach. It doesn't match our understanding of the pathophys of asthma because it doesn't target that underlying chronic inflammatory component.
Exactly. And that's why the next couple of decades were spent figuring out the question of what is the best combination of maintenance inhalers and rescue inhalers for the chronic treatment of asthma.
Before we dive back into the story of outpatient asthma management over the decades and why the MANDALA trial matters, let's define 3 key players in the management of asthma: inhaled glucocorticoids, SABAs, and LABAs. These may be familiar terms for you, but honestly, in making this podcast, we sometimes felt like we were speaking in tongue twisters. So we just want to make sure we start out all on the same page.
Yes. Let's go through the 3 big key players. First, we have inhaled glucocorticoids, also known as inhaled corticosteroids, and often you'll see it abbreviated as ICS. This is going to be meds that end with ONE, like beclomethasone, fluticasone, mometasone, or ones that end with ide, like budesonide. I have a fun way to remember this. When we think of inhaled glucocorticoids, they really own asthma management. So it's going to be all these meds that end with own, like beclomethasone, fluticasone, mometasone. And then you have meds like budesonide that just come along for the ride and end with ide. I don't know if that sticks better, but I like it. There you go.
I've heard worse.
Thought you'd like it.
I can live with that. And then the other 2 are bronchodilators that open up the airways. These are either short-acting bronchodilators, aka SABAs, or long-acting bronchodilators, aka LABAs.
For the purposes of our discussion today, in terms of keeping SABAs and LABAs straight, anytime you hear one that's ending with an OL that's not albuterol or levalbuterol, we're talking about a long-acting beta agonist of LABA. So examples of LABAs are formoterol or salmeterol.
Right. And just to say, of course, there are many other types of asthma meds, including some exciting new biologics that we're not talking about today, but they're also an important part of asthma care.
Yep. And just a couple more terms that we're going to throw around. When we say the word rescue inhaler, we're talking about a medication that a patient takes acutely in the moment of an exacerbation to relieve symptoms, as opposed to a controller or maintenance medicine that someone is taking daily to control symptoms. It can be a mouthful, but we'll do our best to keep it straight.
Yeah, and we haven't even mentioned any brand names yet, which is what our patients and nursing colleagues often refer to these meds as. Symbicort, Pulmicort, Atrovent, Asthmanex, Qvar. The list goes on and on.
So many.
And you didn't even mention the way that I think about inhalers: the red one, the orange one, the yellow one, and the blue one.
Yes.
So if it's this hard and complicated for clinicians who do this all day to keep track of these medications and keep these labels straight, it must be so hard for patients. And so maybe asthma medications just need a little bit of a marketing intern to come in and help out with things.
Amen. Yes. And listeners, we spent hours and hours trying to think of the best way to present the story of the trials and keep all the meds and regimens and endpoints straight. We really tried our best. And don't worry, if any of it goes over your head, we are going to be recapping the high level points for you.
So the way that I see it, the story of asthma management over the decades has been trying to figure out the best way to do 3 things. Number 1, control symptoms. Number 2, reduce the risk of exacerbations. And number 3, minimize negative side effects from the medications to do the first 2.
Yeah. And so in doing that, this required a lot of trials and testing out different versions of outpatient daily maintenance inhalers as well as rescue inhalers.
So Julie, you had just told us about the BAGS trial showing that albuterol as a rescue drug and not around-the-clock therapy was enough to treat asthma in some mild cases. What was the next big leap in asthma management after the BAGS trial?
Yeah, there were a bunch of RCTs over the next couple of decades looking at different SABAs and LABAs along with inhaled glucocorticoids. And it's really hard to compare these studies directly because they studied different patient populations and had different endpoints. But I think the overall message was that inhaled glucocorticoids help treat asthma, and the amount and frequency required depended on the severity of the disease.
Yeah, so we're going to try to summarize 4 trials for you from the last 2 decades: STAY, BEST, Practical, and Novel Start. Obviously, this is not the whole story, but we think it'll help set the stage before we talk about Mandela.
So let's start with the STAY trial from 2004. This is a trial that showed that combining an inhaled glucocorticoid with a bronchodilator and using that combination inhaler for both daily maintenance as well as needed rescue treatment improved symptom control and lung function in patients with moderate to severe asthma.
Okay, so this, along with other trials, were where SMART or MART therapy comes from. SMART stands for Single Maintenance and Reliever Therapy, which basically means using a daily inhaled glucocorticoid and a LABA together in a single inhaler, and then that same inhaled glucocorticoid and LABA inhaler used on top of that as a rescue medicine.
And just to keep things clear, formoterol is the only current LABA that really works with SMART therapy, since formoterol acts faster than the other LABAs, and it can also be used multiple times per day. It's considered a win-win LABA since it has both a rapid onset and a prolonged duration of bronchodilation.
Right. But then people started to wonder, maybe not everyone needs to take a daily maintenance inhaled glucocorticoid at all. Like, what about patients with mild asthma?
And just to say, what is mild asthma? Of course, different studies have defined it differently, but I think one maybe general way to think about it is to think about the rule of 2s. So mild asthma should be someone who is not having symptoms more than twice a week, or night symptoms more than twice a month, or needing systemic glucocorticoids more than twice a year.
I think that's such a good way to summarize inclusion criteria for half a dozen trials. And, so the next trial that we're going to look at is the BEST trial from 2007. This is a trial that studied patients with mild asthma, and it found that as needed rescue combined inhaled glucocorticoid and SABA, and this combination was beclomethasone plus albuterol, was as good as daily maintenance inhaled glucocorticoid, specifically beclomethasone, plus an as-needed albuterol inhaler. And the outcome that they studied in BEST was peak expiratory flow.
Right. The idea of using inhaled glucocorticoids only as needed was reinforced again in 2019 with the Practical trial, which looked at patients with mild to moderate asthma.
Yeah. So in Practical, one group got budesonide and formoterol, which we know as Symbicort, to use just as a rescue medicine. And another group got maintenance budesonide to use daily. We know that as Pulmicort. And then on top of that, a rescue short-acting beta agonist as needed.
That's right. And they found that using the combination med, budesonide and formoterol together, just as needed, was actually better at preventing severe exacerbation, even though that other group was using an inhaled glucocorticoid every day.
Wow. And so arguably the most important takeaway from BEST and Practical is that we can get away with giving less inhaled glucocorticoids overall to patients with mild asthma. You can just use these inhaled glucocorticoids as part of rescue therapy, at least for the outcomes that we looked at in these trials.
Yep. So it sounds like mild asthma patients don't really need daily maintenance inhaled glucocorticoids.
Right. And I love to hear that because minimizing the side effects of medications like glucocorticoids is one of the major goals that we have for asthma treatment. Dr. Drazen had a really good story that reminded us that while inhaled glucocorticoids are less harmful than systemic glucocorticoids, they don't just act in the lungs.
Distinctly remember I had an older patient I started on inhaled glucocorticoids. She says to me, "Well, doctor, this is the best medicine ever. It makes my asthma better, and it's good for my arthritis." Now, I knew what was happening. The steroids were getting in there and helping her arthritis. So we know that there are systemic effects of inhaled glucocorticoids. They're not like water. They do have side effects. And if you can get away with less, you're better off.
So yeah, we certainly had evidence to support that we can get away with less inhaled glucocorticoids from the BEST and Practical trials. But I'm so curious now, can we get away with no glucocorticoids in mild asthma?
That's where Novel Start comes in. Novel Start is a trial from 2019 that compared budesonide formoterol, aka Symbicort, as needed versus albuterol as needed, and found that Symbicort was better for preventing exacerbations in patients with mild asthma who were not on any daily glucocorticoids.
Yeah, so honestly, the Novel Start trial showed us that we can't really get away with no inhaled glucocorticoids in patients with mild asthma. Inhaled glucocorticoids should be in the rescue medication at least.
Oh man, this just makes me feel deeply for the clinicians and the researchers who are trying to juggle the multiple endpoints in managing asthma. It's like a balancing act of the right combo for symptom control, preventing exacerbations, as well as reducing the harms of glucocorticoids.
Exactly. Okay, so if you guys have made it this far through the tongue twisters of asthma medication names and trial acronyms, the worst of the alphabet soup is over. Let's move on to how guidelines started to change after some of these trials.
So a lot of the most important guidelines in asthma come from the GINA initiative, or Global Initiative for Asthma.
And so it was in their 2019 guidelines that albuterol was no longer recommended as a first line for rescue in adults.
Rather, we're supposed to be using rescue treatment that combines both a bronchodilator and an inhaled glucocorticoid.
That's right. This is so important, so I'll say it again. The 2019 guidelines essentially recommend for adults with all types of asthma, the first-line rescue med should be an inhaled glucocorticoid combined with a LABA. For example, budesonide and formoterol together, which is called Symbicort, or mometasone and formoterol together, which is called Dulera.
And for patients with moderate or severe asthma, the guidelines say to use the same combination of inhaled glucocorticoids and bronchodilator as daily maintenance therapy, as well as for a rescue medication.
Yeah, so it sounds like in moderate severe asthma, we can't just get away with a combination rescue medication only. We still need that daily maintenance combination inhaled glucocorticoid and LABA on top of the combo rescue med.
That's exactly right. And I want to just point out these guidelines changed 5 years ago. And so one of the questions I'm asking now is that what all clinicians are really doing?
You know, Greg, I think there's still a huge practice gap. I know for me, before working on this episode, I remember having a patient in the hospital using his albuterol as needed and being like, shh, don't tell anyone, I don't want to bother the nurses, and pulling it out from his fanny pack. And I didn't even bat an eye that he was using rescue albuterol, and it was completely outdated asthma management.
Bat an eye at the rescue albuterol or at the fanny pack?
Neither one. I'm a non-judgmental doctor.
So good.
But bad when it's outdated management.
Well, give yourself some grace, Shreya, because it's not always easy to make these changes happen in real life. One very real barrier is that combination ICS LABAs, like Symbicort and Dulera, are only FDA approved for use as maintenance therapies in the US, not rescue medications.
Wait, what? Really? Despite the guidelines having combination med as both the maintenance and the rescue for smart therapy, it sounds like clinicians are just prescribing this combination inhaler as a rescue off-label. That is infuriating.
I know. So until last year, the only inhaled medication approved for asthma rescue treatment was albuterol. So when a provider tries to prescribe, let's say, Symbicort for both maintenance and reliever, as per the guidelines, insurance companies will say, no, that's not approved as a rescue inhaler, which can mean extremely high copays and insurance headaches for everyone involved. But since the MANDALA trial, a new combination rescue inhaler has come onto the scene. The 2022 MANDALA trial looked at patients with moderate to severe asthma who were already on daily maintenance inhaled glucocorticoids and tested 2 different rescue medications for them. They compared a combined inhaled glucocorticoid and SABA, so budesonide plus albuterol together in one rescue inhaler, versus just rescue albuterol alone.
One of the reasons this study was important is that it was the first to ask which rescue inhaler is better in this population of sicker patients with moderate to severe asthma.
Yeah, and it was also the first to study this specific combination inhaler of an inhaled glucocorticoid plus albuterol. Remember, the other studies looked at combinations of inhaled glucocorticoids and LABAs.
You know, when I first heard this, I was confused why the authors chose albuterol, a short-acting bronchodilator, to mix with budesonide, rather than a LABA like formoterol. I mean, didn't the GINA guidelines in 2019 recommend a combined inhaler with formoterol? So why not just study the LABAs?
I had the same thought, Shreya. I actually sat down with the first author of the MANDALA study, Dr. Alberto Papi, who's head of respiratory medicine at the University of Ferrara and head of their research center on asthma and COPD, to ask him that exact question.
Oh, yeah. What did he say?
So the guidelines didn't recommend combined inhaled glucocorticoid albuterol inhalers, not because they didn't think they would work, but because they hadn't been studied yet. Basically, guidelines recommend things we have RCT evidence for. And what we had evidence for was inhaled glucocorticoids plus formoterol. So all the guidelines recommended that, even though albuterol is the most widely used rescue medication worldwide.
So in other words, the absence of evidence is not evidence of absence.
Right. And yeah, this got me thinking about all the previous studies we just mentioned, right? I'm so curious now, how much of that benefit that we were seeing came from the inhaled glucocorticoids decreasing airway inflammation And who's to say that the combination inhaled glucocorticoid with a short-acting albuterol won't work also?
Yeah, exactly. Dr. Papi also mentioned that he felt an albuterol-containing rescue inhaler would be more easily adopted by patients.
Right. At the time of the trial, the only approved class of rescue medication for asthma in the United States was albuterol. So both patients and clinicians were pretty used to using albuterol for that rescue purpose.
And understanding the patient and clinician perspective in addition to just the researcher perspective really helps bring context to a trial like this. Let's get deeper into what Mandala evaluated. This was a multinational, phase 3, double-blind, randomized, event-driven trial to evaluate the efficacy and safety of rescue combination albuterol budesonide versus rescue albuterol alone. They studied patients with uncontrolled moderate to severe asthma who were already on good daily maintenance therapy.
And then for our med-peds friend listening, did the Mandala trial include children?
Great question. It did, but not very many. The trial included patients aged 4 and up, but 97% of the patients ended up being over age 12. The mean age was 50 years old. So the trial doesn't tell us too much about pediatric patients, unfortunately. Definitely an area for future research.
So then we mentioned that this was the first trial to really ask these specific questions in the moderate to severe asthma population, which then begs, how did they define moderate to severe asthma?
So patients needed to have had at least one severe asthma exacerbation in the previous 12 months. Basically anything requiring systemic glucocorticoids or hospitalization.
Got it. So then who did they exclude?
They excluded patients who had COPD or other major lung disease, patients who had used systemic glucocorticoids within the last 3 months, and patients who had recently used biologic asthma treatments.
And then they took the adult participants who had a severe exacerbation in the past year and divided them into 3 groups. One group used albuterol only as a rescue inhaler. Another group used a rescue combination of albuterol and lower dose budesonide. And then the third group used a rescue combination of albuterol with higher dose budesonide.
And remember, all the patients were already on some form of inhaled glucocorticoid daily as a maintenance medicine since they had moderate to severe asthma, and they continued these throughout the trial.
Yep. So then it looks like they took about 3,100 patients. They went randomization, and the primary endpoint was the time to the first event of severe asthma exacerbation using a time to event analysis.
Julie, do you want to do us the honors of telling us what the Mandala study found?
Yeah, definitely. The study found that the risk of severe asthma exacerbation was significantly lower, 26% lower to be exact, in the higher dose combination rescue inhaler group than in the albuterol alone group. The hazard ratio was 0.74, and the result was statistically significant.
Just to be on the same page, hazard ratios basically compare the risk of an outcome happening in one group with the risk of it happening in the other. If the hazard ratio is below 1, it usually means that the treatment group has less hazard of reaching the outcome first, which in this case means a lower risk of a severe asthma exacerbation.
Nice. So the risk of severe asthma exacerbation was significantly lower in the as-needed use of higher dose budesonide combined with albuterol compared to as-needed albuterol alone. What about the lower dose budesonide group with albuterol?
So actually, the hazard ratio for the lower dose combination group compared to the albuterol alone group was also below 1. It was 0.84, but the p-value for this one was 0.052. So technically, that result was not statistically significant.
Okay, interesting. What about the secondary endpoints? I know one of them was looking at annualized rates of severe asthma exacerbation.
Yeah, the patients in the combination higher dose budesonide albuterol rescue group had a lot fewer exacerbations on average than the albuterol rescue alone group.
Nice. Okay. So now onto the secondary endpoint that I think I'm most interested in, especially after all the discussion we had with Dr. Drazen. So about how much total systemic glucocorticoid exposure did each group have?
Yeah, Shreya, I was really interested in this question too. The patients using the combination budesonide albuterol inhalers ended up getting exposed to less systemic glucocorticoids overall. So participants in the higher dose combination group used an average of 84 milligrams of prednisone equivalents per year, while those in the albuterol alone group used an average of 130 milligrams per year.
So it sounds like if our patients were using combined inhaled glucocorticoid bronchodilator like budesonide albuterol as a rescue med instead of albuterol alone in moderate to severe asthma, we're not only preventing more exacerbations, but we're also sparing them an equivalent of 50 milligrams of prednisone per year, it sounds like. Awesome.
Yeah, exactly. And a similar finding was observed in the lower dose budesonide group versus the albuterol only group in terms of the glucocorticoid exposure as well.
Nice, nice.
On top of that, patients in the higher dose combined rescue med group also reported better scores on various scales that measure quality of life with asthma, which was another secondary endpoint. Plus, adverse events were similar across all groups.
So I'm hearing fewer exacerbations, feeling better day to day, less glucocorticoid exposure overall, and no increase in adverse effects. That sounds like a pretty decent amount of wins across this population.
Yeah, I agree. So let's step back and maybe we can recap the journey of what we knew about asthma management and how the results of the MANDALA trial really add to that conversation.
So we already knew that for adult patients with mild asthma, the first-line rescue medicine should be a combined inhaled glucocorticoid with a LABA. And all the data we had basically looked at inhaled glucocorticoids combined with formoterol. So that's what was recommended as a rescue. Ironically, that is still an off-label use of that medication.
Pains my soul. Anyway, and then in the moderate to severe asthma group, we knew that budesonide formoterol or other similar combinations of an inhaled glucocorticoid and a LABA were effective when they were both used as a maintenance daily medicine as well as a rescue medicine.
And so Mandala gives us a new option for a combo rescue inhaler, this time using a SABA that had really never been looked at before. This combination of albuterol budesonide seems to work really well for adults who are continued on their various daily inhaled glucocorticoid controller medications.
Right. And because of the MANDALA trial, the FDA approved a new high-dose budesonide albuterol rescue inhaler in January of 2023, which is for patients 18 years or older. If you're looking for it in your patient's charts, the brand name is Air Supra.
One thing that I found really exciting about these results was something that I observed about the Kaplan-Meier curves in the MANDALA trial.
Oh man, it won't be a Beyond Journal Club if Greg does not bring up the Kaplan-Meier curves.
My favorite curve and what I see when I close my eyes at night before I go to sleep. And
I wonder that sometimes, Greg. But yeah, lay it on us. Come on.
so the Kaplan-Meier curve in this study is really interesting because it shows the biggest change in the trajectory up front. And so what that says to me is when you find these patients who are vulnerable with uncontrolled moderate to severe asthma, getting them on the right medication sooner has an upfront benefit in preventing more severe exacerbations in this group of patients.
Right. And just to hammer this point home about the pathophysiology, this does make sense. When patients have asthma symptoms, they do better when they get an inhaled glucocorticoid as well as a bronchodilator in their rescue inhaler, because the glucocorticoid can reduce underlying inflammation while the bronchodilator provides relief in the moment.
So this all sounds great. I'm kind of sold, and I'm wondering, should we just stop prescribing albuterol rescue inhalers completely in all our adult patients?
That's a great question. The answer is probably honestly yes. But of course, in medicine, it's never a one-size-fits-all answer.
And so I think if you're taking the literature seriously, it definitely means that albuterol inhalers don't really have much of a place. But in talking with pulmonologists in prepping for this episode, I think it's worth noting that there's a huge difference between a patient who's well controlled on maintenance therapy and uses albuterol once or twice a year compared to the patient who carries their albuterol with them all the time and doesn't feel comfortable leaving home without it. That's the patient who should be switching. For the patient who's well controlled, I'm really not sure that we need to convince that well controlled patient to spend money on a new inhaler or to adjust the routine that they've gotten used to.
Yeah, especially because some patients have limited access to certain meds based on insurance, money, geography, personal preference, so much.
That's so true. But, even if our patients can't get the combination rescue inhaler for one reason or another, we can actually still optimize our patients' care just by changing how we counsel them. If a patient has two inhalers, an inhaled glucocorticoid and a SABA, the clinician can tell them to just take both of their inhalers together when they feel sick. That kind of simulates the combined inhaler effect.
Dump your albuterol inhaler or your short-acting beta agonist for an inhaler that has both. And if you can't get both, carry with your albuterol inhaler an inhaled glucocorticoid of your choice. And when you use one, use the other. Don't leave home without them. You'll be better off.
Yep, that's the new message.
And that workaround treatment, using both inhalers at the same time, is actually exactly what the GINA guidelines recommend.
It is wild to me that the guidelines have explicit recommendation on workarounds of insurance madness. I hope people listening from other countries have much fewer barriers than I think we do in America.
Yes, I sincerely hope so too.
So now we have to change the behavior of almost all the doctors in the world. Because most doctors have been educated up until 2015 We're taught that when someone has a little breathing problem, you give them albuterol alone.
This makes me so glad we're spending time doing this episode, and I hope we're making a small but mighty dent towards this goal. I think we should all be using a trial like Mandela as a call to action, right? Any of us prescribing albuterol without really understanding the disease is not doing right by our patients.
So Shreya, I so admire you for the idealistic take on Mandala, which is to use it as a call to action that we need to do better by our patients. The cynical take here is that anyone who's been paying attention to the asthma literature for the past couple of decades knows that combined therapy in the setting of the need for a rescue inhaler is better than just albuterol alone. And AstraZeneca was able to capitalize on this hole in the FDA approval process to make a lot of money by getting Air Supra approved. And, it's probably a combination of the two, and the cynical read isn't entirely the correct one. But I wouldn't be able to sit on my hands and be quiet if I didn't point out that there's a cynical view of a trial like this too.
I appreciate that realism, and sure, that is probably very much the story, but I very much agree with you, right? We have known this for decades, right? Wasn't it 2004 with the STAY trial, right? That we learned about smart therapy with maintenance and reliever combination, and it's been 20 plus years now. So it makes me really sad, because I think like as a society, we've probably just accepted that patients with asthma are not going to feel great from time to time. And even patients and clinicians are like, oh, well, at least they're getting some relief from the bronchodilator that they have, but it's clearly not enough.
Yeah, I do not think we should settle for just some relief for our patients. We have evidence now that we can prevent exacerbations and get patients to feel better day to day if their rescue inhaler has an inhaled glucocorticoid in it.
And since it's a rescue med, we're basically using the patient's symptoms to kind of guide how much glucocorticoid therapy they need, and hopefully in that process, less systemic glucocorticoids, which I think a lot of people can get behind.
Yeah, really quick, I feel the need as a pediatrician to remind everyone that before you decide a patient's asthma is poorly controlled, just make sure they're using their inhalers and spacers correctly. None of these medications will do any good if they don't reach the lungs.
Oh, so true. And I learned this from actually Pearl 3 on the COPD episode, that the most important thing we can probably do is to observe our patients, and if needed, correct them on how to use that specific inhaler delivery system. I also learned from that episode that pharmacists are also pretty well trained in this and can help us out. So I love that we can also use our interprofessional colleagues in this mission.
Yeah, that's exciting. Another thing I'm excited about is the graphics that Dr. Jimin Huang did for this episode.
Yeah, I think visuals are so important, and I'm certainly going to be pulling this up in my counseling conversations to show the difference between, hey, this is your lung when you're using a bronchodilator versus here's what your lungs look like when you use an inhaled glucocorticoid plus a bronchodilator. I think we just really need all hands on deck with trying to change this practice gap that we have. And I welcome listeners to write in and let us know what tips they have to have clinicians and patients be using these evidence-based inhalers.
Yeah, and please also write in to tell us how you keep all these meds and brand names straight. Do you have better mnemonics than us? I hope so.
I sincerely hope you do. And so there you have it. This has been the 5th edition of Beyond Journal Club with NEJM Group.
And that is a wrap for today. If you found this episode helpful, please share with your team and colleagues and give it a rating on Apple Podcasts or whatever podcast app you use. It really does help people find us.
Thank you to Dr. Yuchi Zhang for audio editing. If you have any feedback, please email us at hello@CoreIMPodcast.com. Opinions expressed are our own and do not represent the opinions of any affiliated institution. Thank you.
Save big on brunch for mom, all in the Baker's app. Get 3-pound packages of flavorful Kroger 80% lean ground beef for $3.99 a pound. Then buy 2, get 2 free on 12 packs of delicious Coca-Cola, Pepsi, or 7-Up, all with your card. Shop these deals at your local Baker's, less than 10 miles away. Or tap the screen now to download the Baker's app to save big today. Baker's, fresh for everyone. Prices and product availability subject to change. Restrictions apply. See site for details.